Hello, everyone. Speaking to the three-dimensional audience and the virtual audience outside watching this online. Welcome to the Kline School of Law and to this attempt. It launches a new webinar series called Signs for Us. Thank you for coming. I want to first say thanks to the Kline staff who helped us put this together. Quite an enterprise to do a hybrid operation. We're now Clapper, Brian Burke, Mallory Heller, Jason Feldman, Alec Lynch, and Mary McGovern. Thank you all very much. Now for the main event. My task is to introduce the speaker, Kim Gunter. I've known Kim since 1998. She has taught my classes on HIPAA and privacy. I followed her career through different job changes. And so I claim some knowledge or expertise. Kim is the Vice President and Chief Compliance and Privacy Officer at Drexel. She oversees activities related to the development, implementation, maintenance of, and adherence to Drexel's policies and procedures on privacy of and access to sensitive information. And in a world of ransomware, phishing, spam, she's got a very big job, and she writes a wonderful newsletter aimed at the Drexel employees and faculty, updating us regularly on crises and what to do with them. She also oversees the university's adherence to federal, state, and local regulatory requirements, the university's policies and procedures, code of conduct, conflict of interest programs, Drexel compliance hotline programs. This is the new administrative state in action within universities. More and more compliance. Kim holds a BA in business from Georgetown University, a law degree from Villanova, a master's of law from Widener, where she was a student of mine, and a master of divinity degree from the United Lutheran Seminary. He's also heavily certified in all the things one is certified in. Management, risk management, compliance, information privacy, so many certificates. He's a remarkable combination of legal, compliance, and privacy expertise. And for today's talk, she also has remarkable expertise in years of lived experience and passed down histories of healthcare encounters of the negative kind. Her talk today is another step toward the goal of effectuating change in the communities we live in. She has developed a rich collection of information she will share with us regarding the realities and inequities many African Americans face in taking part in the U.S. healthcare system. The title of her talk, as you can see, is African Americans in the U.S. healthcare system, a history of mistrust. Kim, it's all yours.
Thank you. Hello, it's so good to see you all. I am pretty loud. Do I have to use the microphone or can you hear me well enough? I wonder if the people online can hear. I don't know.
Microphone, please.
Microphone check, okay. Okay, I will put on. Thank you. I want to thank you for having me. It's a privilege and an honor to be here. I have also, since I always call you Barry. I don't want to do that. Dr. Ferrel has been here. I've been participant here at Drexel as well before coming to work here in 2019. So, and I'm also happy to say there are members of my staff here. Please raise your hand. I know they don't want me to ask them to do that, but please raise your hand. I am very happy to see them here. So thank you so much for coming out. So let's get started. I have, come on. All right, it's not moving. The IT guy. Oh, I have to do it that way? No, you shouldn't have to. Okay. Oh boy. It's going to see how much I remember.
This is a brand new room, brand new technology, which is state of the art.
But we're not.
We're not. Well, you can hear me, but Okay, we'll need to get him back in here. I think that's for the camera. Okay. Right, I think it's- Mhm. There we go. Thank you. No problem. Thank you very much. So I must say this, these are my views, thoughts, and opinions and ideas, not that of my employer or any associations or organizations that I am associated or affiliated with. That's required. So there's that. So for our discussion, I want to ask you, I have some up here, but what do you think are some facts about African Americans and the healthcare system? There's probably some things that you think sometimes you're uncomfortable talking about them, especially those of you who aren't Black in the room. You're probably very uncomfortable saying them because you may feel like you'll sound racist. But you've heard some of these things before. Black people avoid the doctor. Black people believe that doctors are the devil, and especially non-Black providers, but Black providers are brainwashed. The doctor-patient relationship is not for Black people, that's for white people. That's a white phenomenon. Providers will use Black people as guinea pigs. Doctors will let them die or will kill them. There's another part of that you don't want to put that you're an organ donor on your license because they will let you die and take your organs. As a matter of fact, I have believed that, and I am not an organ donor. Current diseases affecting the Black community were planted by the government, such as HIV, AIDS, and COVID-19. Has anybody in here ever heard any of those things? Yeah, okay. Have you heard anything else that I don't have up here? Anybody willing to say? Yes.
I think it's Serena Williams, like not being listened to by doctors, and she's like, I know my body, I'm an athlete, listen to me, and they just wouldn't listen to her.
Yep. So doctors don't listen to Black folks. Yes.
That medical providers think that Black people can't feel pain.
Yeah. Okay. So where did all this stuff come from? Where did this come from? So is it fact or is it fiction? Is this really the case, or did Black folks just make this up? Here are some statistics from the government statistics that African Americans are more likely to die in early ages from all causes of diseases, but especially high blood pressure, diabetes, and stroke. Black women are up to 4 times more likely to die from pregnancy-related complications than white women. Black men are more than twice as likely to be killed by police as white men. And the average life expectancy of an African American is 4 years lower than the rest of the US population. Is that striking? Or we kind of know this, right? And what are some of the contributing factors? Income level, the cost to healthcare, getting health insurance, being able to have access, therefore, obesity. Think about some of the food deserts that a lot of low income and a lot of African Americans live in. Unemployment, especially after COVID, right? Activity, some people just don't exercise, right? You live in compacted places and places where there may be high crime. Where do you go out for a jog or a walk? Do you feel safe? Smoking, have to release some kind of way, right? If you can't go out and run, where's your activity? Some people smoke, it helps. And we never want to talk about it, but racism is a contributing factor. So the fact is, and it's actually these are not my words that I'm saying on this slide, but being Black is bad for your health in America. And there's pervasive racism is the cause. This has been studied, and there are scientists who have actually said this, that being Black is bad for your health in America. We do know that health inequities at their very core are due to racism. kind of hard to hear. Not so hard for me to say because I've done this presentation many times, but recent research has also shown that racial health disparities don't just affect poor African Americans, but cut across all class lines, socioeconomic lines. He just talked about Serena Williams, and we'll talk about her a little bit today too. But you've heard stories of famous people who have had issues at the airport, you name it, just driving down the street in their own neighborhoods. Why wouldn't that translate to the healthcare setting? And as of August of 2021, there are many locales that have declared that being Black or racism is a public health crisis in America. And actually, I have newer statistics than what's up there. There are 246 places or leaders in the United States as of April 5th, 2022, who have said that racism is a public health crisis. Think about that, a public health crisis, not just something that you just kind of know about or that Black people just complain about, but an actual public health crisis. And so, is this real? I'm telling you that people have studied this and these are their conclusions. Is this real, or is it fact, or is it fiction? And if it is in fact true, then what are the justifications for the beliefs that Black people have about healthcare? Where do these things come from? Why do Black folks, and I'm talking very generally, there may be Black people in the room right now who say, I trust my doctor, right? But where do these ideas, where do these thoughts come from? What is the basis for all of this? And I'm going to talk about that. But before we start, I want to go talk about some basics. You heard that I'm a privacy and compliance officer, so I have to do the required privacy and compliance discussion. So here's a little training on compliance and privacy. This will not get you out of any training if you need to have it wherever you work. But this will help a little bit as we talk. I want you to think about these ideas of privacy and consent in terms of, and especially as I think about them in terms of the privacy program we have and compliance programs. But privacy is the appropriate use of personal information for the circumstances. So if I need to treat your broken leg, I need to know something about your bone structure. I need to know whether you've broken this leg before, something about your history. I may not necessarily, depending on the type of fracture, and we have a doctor here, so I'll let the doctor get into that, but I may not necessarily need to know everything. I necessarily need to know about your eye surgery to fix your leg, right? But I do need to have some information about you. And it's also, the individual has a right to control how information about them is used and disclosed. Consent has to do with an individual's right to know the consequences and risks, and as well as the benefits associated with what is going to happen to them. What are you going to do to me? So that I have a choice as to whether I let you or not, whether I consent to it or not. And we're not talking about emergency situations, right? But we are talking about experimentation. We're talking about, I'm just an individual, I'm coming to you for care, and you think that I should have a certain procedure. Well, you need to tell me what that procedure will entail, and I will then say, yes, okay, I understand the risks, I understand the benefits, I'm going to move forward with this, right? That's part of consent. And I put up there about sensitive personal information or data because in the EU, these are the factors that, in the European Union, these are the factors that constitute sensitive personal information. So what is personal information? Your name, your address, your social security number, your driver's license number, your passport number, your personal information, even it could be your web address, right? The URL for your home computer, it could be personal information. It depends how it is defined in the law in the US. But in the EU, there's a section, a category of personal information called sensitive personal information. And I want you to look at those: race or ethnic origin, political opinions, religious and philosophical beliefs, trade union membership, health, sex life, sexual orientation, genetic and biometric data. Think about why those might be considered sensitive personal information in the EU. And by the way, in the EU, there's also a constitutional right, a general right to privacy. We don't have that in the US. So here, these are special categories. As I continue, think about why those might be special categories of personal information. So in addition to just some background and some basics and some of the myths, I'll say that in air quotes, there's something else that we need to understand about those so-called myths, and that's the history. The history of African Americans in this country and experience with the healthcare system. And I will mostly be talking about US funded or US endorsed experimentation on African Americans in this presentation today. And so it started with slave experiments in the 18th and 19th centuries. So this was marked by dissection, grave robbing, trafficking, profiteering, just taking African American bodies and experimenting on them. There was one where severed healthy brains of African Americans were taken if someone had a head injury. Just take their brain out, right? Removing limbs from, especially women. Women were definitely mistreated and used for experimentation. So taking out a lymph node because of a cancer patient in her head, just taking it around her head without anesthesia, and then her head swells. Removing bones from an enslaved woman, Lucinda, from her head, again without anesthesia, around a growth on her head, and it swelled to grotesque form. And that may seem like that's not that bad, right? Maybe? Does that seem bad? Any reaction to that? Enslaved Africans and African Americans were subject to whatever their master's choices were from them. So in response to ads for sick Negroes, slave holders would happily hand over their enslaved because they would either, especially if they were elderly or sick, because they would either get back a healthy enslaved person who could work for them, or if they weren't treated, then they would get money for the bodies, right? So one way or the other, you were going to make some profit out of this. And to actually accurately determine the value of Black bodies was one of the key reasons for Southern doctors. So using enslaved individuals and going to Negro hospitals was a way that white medical students were able to learn by using the bodies of the enslaved. And Negro hospitals, without saying, were the disease in those hospitals because there was not really a focus on treatment. There was a focus on experimentation, understanding the human body without any focus on the human being. Moving on, sick enslaved in Negro hospitals, as I said, meant that the holders would receive either a healed enslaved person or money. Anyone ever heard the term drapetomania? That was runaway slave syndrome. So if the enslaved person wanted to run away, they had to have a mental defect because enslavement was good for Black people, right? It was good for Black people. And so Samuel Cartwright's report on the diseases and physical peculiarities, I can't say it, of the Negro race intended to cure this drapetomania, because there had to be something wrong with an African-American enslaved, an African or African-American who was enslaved who wanted to run away, because slavery was good for Black people, right? One of the atrocities was John Brown. And John Brown was made to sit on a pot in a pit that had been burned. You know, the embers, the coal or wood or whatever was burned. A pit was dug and wood was put in there, burned until it was increasingly hot, right? And then the embers, water was put on the coals or what have you. The embers were at sufficiently hot enough for the testing of his holder. And then he was lowered into the pit naked to sit, because the test was to figure out how deep is Black skin. Can Black people really feel pain, to what you said earlier, right? So put him down there and put water over him, put a towel around him, only his head out, and he had to sit there, right? Now, mind you, this was after a full day of working in the field. and then take them out, administer some heat remedies, and then test the blisters again to see how deep does black skin go? Could you burn through black skin? Do black people burn like white people? Do we have similar skin? That was the test, because of course, black skin has to be different, right? And then how many people have heard of Dr. Sims? A couple years ago, and some statues and things have been taken down and new ones have been put up. But James Marion Sims conducted numerous tests on African-American women, three notably, Anarcha, Lucy, and Betsy, without anesthesia. He was a gynecologist, right? Some of the tools that are still used in gynecology today are named after this doctor. And these experiments were on African-American women, again, without anesthesia. But it wasn't just African-American women. We often hear about Dr. Sims and African-American women, but it wasn't just African-American women. He was a gynecologist and obstetrician. And so he also experimented on babies, infants. In one experiment, he took Black babies and he would take them from their mothers and using a cobbler's tool, open their brains and their skulls to release the skulls because Black brains grew too fast for the skull. And that's why Black people weren't so smart and had inferior brains. So he had to open the brains to release open the skull to release the brains. Imagine that on little babies. Reinforcing the idea that Black people needed some help, right? They were other. So when you can other people, you can perform these types of experiments. And despite all of this, doing this to African Americans, but using the learning to help white people, right? So how do you not see that we're the same? Moving on, as all of this is happening, this isn't happening in a vacuum. This is happening with the backdrop of the legal activity, right? So in 1857, the Dred Scott case occurred. And in that case, the judge said African Americans had for more than a century before been regarded as beings of an inferior order and altogether unfit to associate with the white race, either in social or political relations, and so far inferior that they had no rights which the white man was bound to respect, and that the Negro might justly, and lawfully be reduced to slavery for his benefit. He was brought and sold and treated as an ordinary article of merchandise and traffic whenever a profit could be made of it. So this is happening while Black folks enslaved people are being experimented on. This is the legal backdrop. The 13th, 14th, and 15th Amendments are passed of the Constitution, and then there are the slaughterhouse cases occur. And in the slaughterhouse cases, the ruling, part of the ruling was that the Privileges and Immunities Clause of the 14th Amendment only protected the rights of national citizenship for African Americans and placed no new legal obligations on the states. The Southern African Americans were powerless to fight for their rights in the states. Slaughterhouse Supreme Court only banned the states from depriving Black people of their equal rights. It did not guarantee that all citizens, regardless of race, should receive equal economic privilege or equal social privilege. This is why we can have the types of experimentation that was happening. This is the legal backdrop. And then there's Plessy versus Ferguson. And this is the court that held that Blacks should have access to separate but equal accommodations. So that gives you an understanding from a legal perspective how this could happen. How can this be? But then we move on. So in 1932, and how many people have heard of the Tuskegee experiment, right? Everybody's heard of Tuskegee. Did you know that it occurred for 40 years? And did you know that there were Black people, Black doctors, and Black nurses who were asked to help to recruit for the Tuskegee Project? So for those who don't really know what the Tuskegee experiment was, Black men in Alabama with syphilis were part of an experiment, and they were told that they had bad blood. And that's why they were part of this experiment. They were not told that they were being denied treatment for syphilis. They were not told that they would receive treatment, and most of them did not. And in addition, any of the men who wanted to enlist in the draft, because World War II occurred, right? So, or Korea, any of them who wanted to enlist were denied, because if they had enlisted, they would have received treatment, right? They would have received treatment for syphilis. And so at the time, you may wonder, how could this, I get that this happened, but how could it happen? Why would they want to deny Black men? Why would you single out Black men for this treatment? Well, it was widely believed that while the brains of African Americans were under-evolved, the sexual appetite and genitals of African Americans were overdeveloped. And so that was, they were seen to have, especially Black men, seen to have an intrinsic perversion for white women, and all African Americans were seen as inherently immoral and to have an insatiable sexual appetite. So we want to study the African American men and untreated syphilis in Negro men, because of course, African Americans have this insatiable sexual drive, and it's okay if we don't give them the medication that was needed. And so the effort was to study these men. Now, if you look at this timeline, you see that penicillin was available in the 40 years, and penicillin became the preferred treatment for syphilis, but these men were denied. So in addition to the doctor and the nurse who helped with recruitment, 127 Black medical students were rotated through during this treatment. And it took until 1972 for someone to report this and blow the whistle on this case. In 1997, President Clinton apologized for this atrocity. I do want to note that during those years, in 1954, Brown versus the Board of Education occurred, which overturned Plessy versus Ferguson, separate but equal. And with all of this happening in the backdrop, the Tuskegee experiment continued until 1972. So let's look at what else was happening. The Henderson Act occurred in 1943, which required testing and treatment for venereal diseases in the United States, publicly funded. These men had no access to it, purposely. Penicillin, I told you penicillin became available. The experimentation of penicillin occurred, and it became the standard treatment in 1947. But these men were denied until 1972. The Nuremberg Code and the Declaration of Helsinki, worldwide understanding of what should happen with research subjects and the ethical treatment of research subjects, informed consent. But these men were never told the truth about what was happening to them and that they were not receiving treatment. And then the congressional hearings and the NAACP class action occurred finally in 1974. The families received $10 million award for survivors and family, and for children who were born with congenital syphilis because their fathers weren't treated. I want to mention that one of the men who were part of the Tuskegee experiment, the last survivor, a man named Mr. Ernest Hendon, passed away in 2004. So that's the extent. When you think about that as ancient history, he died in 2004. That's just 20 years ago, right? So we're not done with the history. In 1945, while driving his truck, Mr. Ebb Cade had a horrific accident where he broke just about every bone in his body. And he was taken to a nearby hospital in Tennessee. Everyone thought that he would die. He lived. But before they treated him and reset his bones, he was injected with plutonium. He was injected with 4.7 micrograms of plutonium. That is more than 40 times the normal lifetime exposure to plutonium. He was never told. And when the doctors extracted bone chips and pulled 15 teeth from him to measure the elevated plutonium levels, they still didn't tell him. And he knew something was wrong. It took them 5 days to set his bones, even though he was still alive. They decided to inject him with plutonium. And then one day they were going to inject him again, and he wasn't in his bed. He got up and left. He said, enough of this. I'm out of here. And he left. He ended up living until 8 years later, he died, and not from the plutonium exposure, believe it or not. He died from heart failure. But he got up and left and found out what had happened to him. But he's not the only person who ever received who were subject to chemical experiments. Our troops, remember I mentioned the war, World War II. Troops in World War II were exposed to chemicals. Black troops were forced into doing calisthenics and gas masks. And this was part of what was called patch tests and field tests, where they were subject to exposure, but then had to perform in combat to see what it would be like if you performed in combat. There were also patch tests where liquid mustard gas was applied directly onto the test subject's skin, because they wanted to test to see the effect of the gases on Black skin. Chamber tests where men were locked in gas chambers while mustard gas was piped inside until the men passed out. And one of the survivors said, we were being tested to see what would happen to Black skin, to see what would happen to us, just because we were Black. But then there were Japanese as well. Japanese were used to see what is the enemy like? So we'll use Japanese subjects to see. And Puerto Ricans were also tested to see how they would survive and how the enemy would survive. So enlisting in the military also got you subject to what you thought you might be escaping here in the United States. In the 50s, the CIA and the military released millions of infected mosquitoes with mosquitoes infected with yellow fever in Florida. And I have to step back and give a little bit of a personal story here, because my family is from Florida. And I remember as a 10-year-old going to Florida with my grandmother, who was born in Florida. And my grandmother was born in 1905. So she was born in a very Jim Crow, post-Reconstruction Jim Crow Florida. And I was there in the 70s. So now I'm telling you how old I am, but I was there in the 70s with my grandmother. And I remember running around at the lake and going to pull Florida, right? You want to eat the oranges and the fruit, and going to pull. And my grandmother and a very dear friend of hers stopped me. You don't know what's in that. You don't know where that came from. You eat what we give you. You don't just grab and eat stuff. Because in Black neighborhoods, the mosquitoes were released with yellow jacket or yellow fever and other kinds of diseases, to see how those agents we would react in case of any kind of warfare where those agents were released in our community or in the United States. So we drop it in Black neighborhoods to see how do people react to that. And I'm not telling you stories that just happened. This is there were programs to do this, right? So 1951 to 1974, this is getting a little bit closer to home. This is Holmesburg Prison, so in Pennsylvania, where dermatological tests were performed on prisoners. So now we've moved from enslaved, we've moved from just Southern Black folks, we've moved from the military, now we're moving into confined people and prisoners. So dermatological tests were performed at Holmesburg Prison by a Dr. Kline. And initially the tests were for treatment of athlete's foot. It then moved into deodorants and other things. And the thing about it is that this doctor anybody ever heard of Rahn? He founded Rahn. But the experiments were unethical. Another story, my sister, early in her career, she's also a lawyer. Early in her career, she was contacted by a former inmate at Holmesburg because he felt that there were some experiments that were done on him in his skin that was unethical and not right. And he wanted representation. And he was part of these experiments at Holmesburg Prison. So you never know who may come to you seeking some advice or you as an advocate for them. Fortunately, in Pennsylvania, although Dr. Kligman was a member of the College of Physicians of Philadelphia and did receive the Distinguished Achievement Award earlier this year, the College of Physicians apologized, not because they were part of the experiments, but because of their silence about this doctor and the experiments. And he died in 2010, but earlier this year, they removed and stripped him and his legacy of that distinguished award. I wish that was all. I wish the experimentation, I could say it's over, but it's not, and it continued. From 1960 to 1972 in Cincinnati, Dr. Sanger and 15 other doctors and researchers performed whole body lethal dose radiation studies at Cincinnati General Hospital Tumor Clinic on terminal cancer patients. These patients were not notified, were not informed of what was happening to them. This research was funded by the Pentagon and HEW. HEW, for those who may not know those letters, was the Department of Health, Education, and Welfare, the predecessor, federal department predecessor of HHS, Health and Human Services, and as well as the Department of Defense. And 89 patients with an average IQ of 89, average age of 59, and 3 children, ages 9, 10, and 13. 62% of those who received these treatments were Black, and none of them had received written consent at the initiation of this experimentation. But in 1965, consent forms were administered, but they didn't mention the relevant side effects. And then in '69, after the NIH came in and evaluated the program, the evaluation forms were changed, but it did not mention the risk of death. So were they consented? 1994, after President Clinton initiated an advisory committee on human radiation experiments, the families filed a class action lawsuit. And there, the family said, even though these consent forms were given, most of their signatures were forged. Getting a little bit closer to 2023, in 1993 in New York, a mother whose son, her oldest son, was in the prison system. He was 16 years old, had been convicted of armed robbery. And so the State Psychiatric Institute with Columbia Presbyterian Hospital initiated experimentation to determine the propensity of African-American boys and Hispanic boys to have a violent gene. They were genetic. His little brother, 6-year-old Isaac, was going to turn out just like him, and they wanted to study what is it in these African Americans that caused them to be so violent and become criminal. The mother said that doctors told her that the controversial drug fenfluramine would not have lasting effects. Her son, Isaac, the youngest, had severe headaches, was very irritable, and had other hyperventilating, had angry outbursts, and they believe it was directly related to the drug that he received. She was never told the true purpose of the study, but instead Isaac was given $25 gift cards to Toys R Us, and the mother was given $100 every time they came in for the testing. If you come to people in low income areas, and you give them $100 and $25, and tell them that you will help their incarcerated child if the little one is subject to this experimentation. What is a mother to do? Miss Johnson did sue. In 1999, she sued several doctors as well as the city of New York, the Psychiatric Institute, and Columbia Presbyterian Hospital, alleging racial discrimination and breach of confidentiality over the release of her oldest son's records. In 2003, Columbia University, the Leon Lowenstein Foundation, New York City, as well as 2 of the researchers were released from the case on summary judgment. However, many of the researchers were denied summary judgment and were subject to medical malpractice, claims of negligence, and breach of statutory duty claims. I did not and was not able to find what the final result of the lawsuit was. So what do we do about this? We have this history, and I could go on and on. There are many more. There's a whole book, and there's a lot of research out there on this. What more is there to do, right? And so remember those myths in the beginning that we were talking about? And some of you raised your hand and said some other things about why Black people may mistrust the healthcare system. Do you see that maybe some of those reasons for distrust are not are not crazy? Maybe they're not fiction. Maybe there's reason for some of these things. And by the way, these stories are passed down, right? Sometimes, like I said, my grandmother didn't tell me that they dropped all this stuff in Florida, but I was told, be careful about eating the fruit, right? I don't actually know anyone who was denied treatment because, who was denied life-saving treatment and their organs were taken, but you kind of hear these stories. So do we kind of understand that there is some reason for these beliefs and for this distrust? Does everybody, do you agree that maybe there's a reason? So in looking at this and some of our more recent discussion of this, Alice Drager said, African Americans who distrust the healthcare system see plenty of reasons all around them to do so, and they don't have to look back 40 years. So I stopped in 1993, but we could keep going, right? If you think about the civil rights movement, if you think about Medicare and Medicaid, just because you have Medicare and Medicaid doesn't mean that you're going to be treated well, right? State government-funded healthcare, does that mean that you're going to receive good treatment? Maybe, but what are the presumptions about folks who are on Black people that come in on Medicaid, especially, bless you? The treatment of soldiers returning from war, Iraq, Afghanistan. I do know how to spell Afghanistan, by the way, so forgive me for that. Homeless people who end up in the hospital. Mental health stigma in our community, and so ashamed to go get treatment, and then when you get treatment, maybe you're not listened to. The war on drugs and I should say in the 1970s, 80s, and 90s, and then the opioid crisis. And I noticed the different words. The war on drugs, especially crack, we're African Americans mostly. We had to have a war on that. But the opioid crisis is a crisis that everyone should be concerned about. That's mostly white. Even how we term the different national issues that face us as a country, depending on who's at the center of it, we have different words. Racial profiling, that's always been the case. It's not just a 1990s or 2000s phenomenon. Normalizing killing of Black bodies. So you think about the Negro hospitals and the using enslaved individuals for testing and what have you, and normalizing. That was also at the same time as Jim Crow and lynching, normalizing seeing Black bodies just dead and misshapen and mistreated and abused. We see that on the news when a Black person's killed by the police. How many people have watched the latest video? I guess, frankly, I don't know who was the last person killed. And I'm ashamed to say that. Was it Tyree Nichols? Did everybody see that video? We watch it. So you normalize the killing, the illness, the body, the blood of Black people, especially Black men in that situation. I would advise and encourage you to go to the Harvard implicit.harvard.edu for the implicit bias test, because there are many different categories of testing there, and you will see what your own biases are. And you might be surprised when you do the testing. And so what are the implications of all of this? As I said, these stories are passed down, and they're passed down in different ways. You know, we may not sit at the foot of an elder and hear these stories, but they come out in different ways. No, you don't go to that hospital because they don't treat Black people right there, right? No, don't go to that doctor. You got to go to a Black doctor, right? And then there is the whole issue of the importance of representation. When I go into a hospital or when I'm able to choose my own doctor, I do prefer to see an African-American doctor. I don't have a lot of African-American doctors that are on my list of preferred doctors, just because in the area that I may need help, I have had a hard time finding African-American doctors. And why is that? Well, here's some of the numbers. Physicians and these numbers are from 2017, for physicians, there are, at that time from the government, the numbers are 516,000 white doctors to 46,000 Black doctors. And we're talking MDs and DOs. For nurses on the semicircle on the, your right, for nurses, 75.4% white nurses, 23.6% Black nurses. That's better. But we still just don't have the representation. And I believe that people stay where they pray and where they play. So where I am going to be most comfortable is in my neighborhood with my people, with people who look like me, who will listen to me and who will understand when I tell them the stories about what has happened to me and what I'm experiencing. Not always true, then I'm definitely talking in generalizations, but if I happen to tell a Black woman that when I went to the last doctor, I lost 2 children, so I'll share the story. I lost 2 children, and I believe that the doctors who treated me did not take care of me properly. I can't prove it, but I believe that if I'd had a Black female doctor, she would have listened to the things that I was saying and not told me to take some Tylenol. No, I was told to take ibuprofen while I was pregnant. That didn't feel right. I had a fibroid that was growing faster than the baby and outpaced the baby. I ended up losing the baby. And the things that they did to me in that hospital were horrific. But what do you do when you're hurting and you're sick and you're in pain and you just want help? I believe I was treated like an animal. And I know it's because of the color of my skin. I know it is. But what was I supposed to do? I was trying to save my baby. I ended up losing my baby. This is real. So there's a prevalent lack of understanding, and there's a prevalent lack of trying to understand. Don't just give me drugs or deny me drugs because you believe that I can take more pain. There were nights I was on the floor throwing up and in so much pain I couldn't walk back to my bedroom. And when I went to the doctor, they said, well, you'll be all right, just sit there for a few minutes. Does anyone know who this picture is? Can you see it? Can you see the woman in the picture? It's kind of up there on the screen, but that might be too small to see. So let's talk about Black women and girls in this experimentation situation. So I already mentioned 3 women with Dr. Sims in the gynecological experimentation without anesthesia from 1849. Around 1848, an enslaved woman named Harriet was subject to electroshock therapy requiring restraints. Now, she needed restraints, and that was interpreted as a signal that the therapy, the shock was working, not that she needed to be released. And not even once noticing the severe burns on her, she continued to be shocked. The woman in this picture is Henrietta Lacks. Has anybody heard of Henrietta Lacks? So the story of Henrietta Lacks, she was 31 years old when she died. She had cervical cancer, and she went into treatment at Johns Hopkins, a doctor at Johns Hopkins, Howard W. Jones, who sent her tissue to George Gray, who had a gay, who had a tissue lab. Her cells are known as the HeLa cells. They have led to a lot of experimentation, years and years of experimentation and research and discovery. But she was never told that her cells would be used, and her family was never told that her cells would be used. And at the time they started in 1951, it wasn't illegal to take her cells without informed consent. However, by 1974, and remember, this was also after Tuskegee in 1974, the Belmont Report, written by the National Commission for the Protection of Human Subjects of Biomedical and Behavioral Research, led to informed consent implementation in research and the common rule in the United States. And so it became the rule that if you were doing research on me or my my tissue, you needed to inform me or my family, my living family members. They never told them. And so in 2023, the family settled a lawsuit, one of the final lawsuits, with Thermo Fisher Scientific for profiting off of her cells and her immortal cell line. Her cell line is continuing to supply for research today. And then there's a story of going back to 1973, Mary Alice and Minnie Relf. I have their names spelled wrong there, it's Relf. They were part of the eugenics movement in the United States. Notice that Mary Alice was 12 years old, her sister was 14. They were living in subsidized housing, and in Alabama and in a lot of southern states, young women were being sterilized. These two young women were sterilized without their parents' consent, because they were living in poverty, and this was part of the war on poverty, because they did not know how to take care of themselves, and they did have they were not educated. They were in very rural conditions. Their mother, when she signed the consent form that they finally gave her, she signed with an X because she didn't know how to sign her name. And in 1974, just a year later, these young women were introduced to two lawyers, and the lawyers' names were, I don't have my piece of paper, but the lawyers' name were the two lawyers who started the Southern Law Poverty Clinic. And they were able to sue on behalf of these two young women. And so I started with a statistic about Black women and maternal death rates. And I want to take you to something that was said earlier, Serena Williams. We've talked a lot today so far about poor Black people, underprivileged Black people. But when we look at the maternal health rates or the maternal situation for Black women and think about who's affected, both Beyonce and Serena Williams were affected by this in the delivery of their children, not being listened to, not being taken seriously, and being assumed that, oh, they can handle it, it'll be okay. So as I begin to wrap up, what I believe, is it doesn't make sense to just tell you all these stories and not think that there's something that can possibly be done. I think it's more than just assuming that having African-American doctors and nurses is the true answer, because this is systemic. So we need to look back at privacy. Privacy is making sure that the individual has a right, understand the individual's right to have some control over their information. They need to know what information is being collected, why it's being collected, and let the individual have a choice about that information. Consent, make sure individuals understand what is going to happen to them, the risks and the benefits, and promote voluntariness of the individual. They should have an ability to choose whether they're going to participate or not. In order to fight these thoughts and belief, we need to do that with every single interaction. When you walk in, if even with your clients as lawyers, when your clients come to you and they tell you these stories, listen to them. Listen and address the humanity of the individual, not just the story, but the human being who's telling the story. And feel and have empathy for the individual. Respect the individuals. Talk to them. Listen to them. Let them tell you about them. Don't just assume because they live from a certain place, have a certain skin color, have a certain earning capacity, that they're going to follow everything else that your preconceived notions about them. This is Sharon Lindsay. She was the first person in the United States to receive the COVID-19 vaccine. And I think it's important to see her. And she said, unfortunately, due to history, my population, minorities, people that look like me are hesitant to take the vaccine. So before I end, I just want to leave these two quotes. In a world filled with hate, we must still dare to hope. In a world filled with anger, we must still dare to comfort. In a world filled with despair, we must still dare to dream. And in a world filled with distrust, we must still dare to believe. The eloquent and quotable Michael Jackson. And change will not come if we wait for some other person or some other time. We are the ones we've been waiting for. We are the change we seek. Barack Obama. Thank you.
Thank you so much, Kim. Hi, everybody. My name is Liz Kakura. I'm on the faculty here at Drexel, and so pleased to have you with us today for Kim's talk and for some discussion of the many, many important issues that her comments and her stories and her cases and her history and her personal experiences have brought to the fore today. So we're very fortunate to have a brilliant and distinguished panel of discussants who are going to share their comments, reactions based on their work, their experiences, their expertise. We're running a little behind schedule because of some tech stuff in the beginning, but we're going to just proceed with the discussion as planned and certainly understand if folks need to head off to another commitment or to head home. So, am I back? Okay. So just a brief word of introduction for our discussants. To my far right, we have Carla Carter, who's the Associate Deputy Director for Enforcement with the Health and Human Services Office for Civil Rights. Carla provides direct and ongoing support to regional staff implementing nationwide compliance and enforcement programs to protect the civil rights of individuals involved in the U.S. health and human services systems. Ms. Carter develops civil rights policies, drafts regulations, and provides technical assistance to entities and courts to ensure compliance with civil rights laws. She holds a JD from the City University of New York Law School and a BA in early childhood education from Lincoln University. Next to Carla is Jamie Rahn Ballay, who's the regional manager at HHS Office for Civil Rights in the Mid-Atlantic Regional Office here in Philadelphia. Before becoming regional manager, she was the deputy regional manager, a supervisory equal opportunity specialist, and an investigator with OCR, where the focus of her investigations and those she oversaw involved civil rights discrimination issues relating to healthcare access and access to healthcare and social services, as well as enforcing HIPAA. Prior to joining OCR in 2009, Jamie got her law degree from the Drexel University Kline School of Law, yay, and was a member of our inaugural class. And she participated in the Civil Litigation Field Clinic as a certified legal intern for the AIDS Law Project of Pennsylvania, and also held legal internship positions at Community Legal Services and the Homeless Advocacy Project. Jamie's also a graduate of American University, where she got a BA with a double major in political science and interdisciplinary studies, and a minor in women and gender studies. And then next to Jamie, we have Dr. Vanessa Ferrel, who is an internal medicine trained HIV medicine specialist and primary care physician at Drexel Partnership Comprehensive Care Practice. They received their MD from the University of California, San Diego, their MPH from Columbia, and completed postgraduate training in the primary care and social internal medicine residency program at Montefiore Medical Center. As a queer Black person guided by frameworks of abolition and liberation, Dr. Ferrel believes that health equity and health justice can be achieved by dismantling systems of oppression, centering care work and mutual aid, and collectively organizing against interconnected struggles. And so maybe starting there with the focus on health equity and health justice and the many, many interconnected systems that drive bias, discrimination, inequity, and all of these sorts of harm. We'll start with you, Dr. Ferrel. Invite you to offer your comments, and then we'll hear from Jamie and Carla as well.
Hello. Perfect. Good afternoon, good evening, everybody. Super happy to be here. Very honored. Thank you for having me. Thank you, Kim, for your presentation. Very powerful stuff. I just have prepared a few comments, just kind of in reflection of the kind of general theme for today. So I'm Black, I'm queer, I'm a physician. Sometimes I feel like the minoritized aspects of my identity are in direct opposition to my medical training and to my career as a healthcare worker. As we heard, United States medicine has committed substantial atrocities against Black folks, Native folks, Latina folks, folks held in prison and detention centers, disabled folks. The list of harms are inexhaustible and really just, terrifying. The distrust that Black and non-Black communities of color have against the healthcare system and against medicine are founded in these centuries of harm, and they're reinforced by the harms that continue on a daily basis. I firmly believe that medicine is a microcosm of society and that all systems of oppression are invariably replicated in medicine and healthcare. As I reflected on the theme of today's session, I asked myself a few questions. How does my identity as a Black person, as a queer person, shape the way I experience medicine as a trainee, as a worker, and as a patient? How has it harmed me? What does it mean for me as a Black queer physician to represent a harmful system? And how have I inadvertently harmed patients and communities in my role? How do physicians and other healthcare workers acknowledge prior harm and minimize further harm to minoritized and oppressed people? To me, the path to health equity and health justice for marginalized and oppressed people must rely on acknowledging and transforming harm. I'm a lifelong learner and a perpetual student of liberation and abolition frameworks. My current positionality is based on Mariam Kaba's tenets of abolition, which are kind of this triad of refusal, care, and collectivity. At the intersections of health and law, I envision our shared responsibility in transforming harm as healthcare workers, reimagining medical education, reinforcing and upholding patient autonomy, and dismantling our role in surveillance and reporting systems. Starting with refusal, which is defined as only evil will collaborate with evil. Based on history alone, one could very, rightly consider the United States medical system to be an evil system. An important part of reconciling that, and an important part in reversing that course, is for healthcare workers to be intentional about actively abstaining from collaboration with other evil systems. We have all been socialized into a mindset of policing and surveillance. The cops are in our heads and in our hearts. And it is critical for healthcare workers to recognize that our job is not to be cops, nor is it to enforce the law, particularly when said laws infringe on the autonomy and welfare of individuals or minoritized groups. As healthcare workers in certain states or jurisdictions are instructed to report those seeking or undergoing pregnancy termination, to report trans and gender expansive youth, adolescents, and adults who are seeking life-saving, gender-affirming care, to report undocumented immigrants, refugees, and asylum seekers to legal authorities, the stance of only evil will collaborate with evil is a stance that we must commit to take. Even in the absence of directives or rules from these legal bodies, we must apply this practice of declining collaboration with systemic surveillance and policing. We must challenge the systemic criminalization of drug users, of sex workers, of people living with HIV, of currently and previously incarcerated folks, and take action to avoid replicating criminalization within our clinics and our hospitals. We must rethink our roles as mandated reporters and challenge the forced family separation system. We must analyze the role of inpatient psychiatric facilities that serve as an arm of the carceral state. We must be critical of the role that security and law enforcement officers have within the confines of our hospitals. Medical training sets us up to spend our careers promoting and upholding the status quo. Our job, our role, is not to be gatekeepers or to enforce the law. Our job is to provide care and compassion when people are hospitalized during some of the worst days of their lives, and to provide caring support and resources to address and overcome systemic, structural, institutional, interpersonal, and internalized barriers to health. Next, care. Care is the antidote to violence. The United States healthcare system, to me, is implicitly uncaring. Like, how can a system with a tremendous history of harm that rarely admits to or acknowledges its hand in it and is not systematically accountable ever appear caring to minoritized and oppressed people? A system with such rotten roots will hardly be reformed. It must be rebuilt. In care, I radically imagine a better world where the pillars of medical ethics, now pop quiz, beneficence is doing good. Okay. Good answers, everybody. Non-maleficence is do no harm. Okay, cool. Autonomy is freedom to choose freely. That's right. And justice, which is ensuing fairness. So imagining that these pillars of medical ethics are actualized and where a transformative justice lens is applied. Some healthcare workers may be better equipped to fulfill these roles. We've seen studies that prove the benefits of cultural, ethnic, racial, and language concordance in decreasing barriers to health equity for marginalized and oppressed communities. Healthcare workers who care must center patient autonomy and empower patients in self-directed medical care. A patient that knows their rights is a powerful thing to witness. We must educate our patients, our families, our loved ones, and our communities on their rights to patient care and encourage them to assert that for themselves when they aren't feeling heard or cared for. Finally, collectivity, or everything worthwhile is done with others. For me, this assumes several forms that are predicated on interconnected struggles. We know that health is not only impacted by what happens inside the exam room, but even more so, the social and political determinants of health. Social determinants of health equity are grouped into 5 domains: economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and social and community context. As Daniel Dawes writes, political determinants of health, quote, involve the systematic process of structuring relationships, distributing resources, and administering power, operating simultaneously in ways that mutually reinforce or influence one another to shape opportunities that either advance health equity or exacerbate health inequities. In other words, political determinants create the social drivers that affect all other domains of health. Where you live, play, work, and worship, your means and your access to means, your experiences with and access to education and healthcare, the toxins that pollute your air, water, food, and home, your proximity to police violence, the school to prison pipeline, incarceration, historical investment or disinvestment in your neighborhood and community, racism, anti-Blackness, cis heterosexism, capitalism, ethno-nationalism, ableism, classism, etc., all matrices of oppression directly influence one's health. Thus, healthcare workers not only have an explicit duty to refuse to collaborate with evil and to create a caring environment. Care work requires a constant reckoning. We must be in solidarity and act in unison with other disciplines, with justice movements, with organizers, and with all those fighting for a better world. I'm just going to close with this quote from Ruth Wilson Gilmore that I think really is impressed upon me every time I think about it, which is that abolition requires that we change one thing, everything.
Hi, everybody. I'm Jamie Ron Ballay. I'm the regional manager at the local HHS Office for Civil Rights here in Philadelphia. We're right on 8th and Market Street. And I think as I was listening to Kim's presentation, I felt like it was incumbent upon me to get our mission out there and let people know that we're here. We're a very small but mighty shop with what we do. And it's often, unfortunately, the case that people don't know that we exist and they're not aware of the work that we can do and the help that we can provide in these areas. So I think, for me today, I want to get the word out about what we do in this space, as well as talk a little bit about with you where you are seeing issues like this in your community and where we could be of additional assistance to you and the folks that you represent in your practices and for the law students who you're going to be helping in the future. So for me, we are the Civil Rights and Health Information Enforcement arm of the department. In the regional offices, we are really the boots on the ground. I have a staff of 10 investigators. We receive thousands of complaints from the public every year on health information privacy violations, as well as various forms of discrimination. And I thought Kim's talk today was very timely, especially since we're approaching the 60th anniversary of the Civil Rights Act of 1964. And it's clear that we still have a lot of work to do 60 years later. We're seeing, as Kim noted, that even when we control for things like age, comorbidities, income levels, and insurance status, that African Americans and other minorities are still facing a variety of health disparities, and they're still not getting equal access to care and to quality care. And so for our purposes, we do also a lot of community outreach and public education. We try to do a lot of know your rights presentations, and that's another component of, I think people don't know what we do and who we are. So if there are opportunities for us to present that information to communities that you are representing, I think we want to hear about that today as well. And we also provide that education to our regulated community. So in terms of our investigative authority, we can investigate claims based on race, color, and national origin, as well as disability, sex discrimination, age discrimination, and religious discrimination, and a recognition that there are some cross-cutting issues there for our investigative purposes. And we often see complaints come in on a variety of bases for one individual experiencing multiple forms of discrimination. In terms of, our role, we're here to ensure that federal dollars in our health and human services programs that we fund are not being used in a discriminatory manner, and to ensure that everyone has equal access to quality health care, and that when they're engaging with their local social services entities and public benefits offices, that they are being treated with respect and dignity, and that they are being offered equal access to those programs as well. And so our jurisdiction for purposes of race, color, and national origin discrimination lies with Title VI of the Civil Rights Act, as well as Section 1557 of the Affordable Care Act. And so I'm going to turn it over to Carla now to just talk a little bit more about what we're seeing specifically in this space and where we're going with our work.
Because someone said check 1, 2, check 1, check 1. I'm not going to start rapping, though I am from New York and I grew up in the 80s. No, I'm just kidding.
The mic sounds.
Check 1. So excited to be here. This is an interesting time in our history and in this country where there is finally a public acknowledgement of the disparities that Brown communities experience. And more than anything during COVID, we saw what was happening. And though, many try to say that COVID wasn't, a real disease. You know, those of us, including myself, have experienced the loss in our families. And so one thing that Jamie mentioned is that a lot of times we do not get complaints from Brown communities. And it's really disturbing to me. I'm a legacy of this department. My father worked for OCR when it was HEW back in the 70s. And so I have a lifetime of stories of my dad and his colleagues desegregating hospitals, going where things were happening. And so what has happened? You know, no one knows, and we're trying to figure this out now. And Jamie and her team, as well as another regional office, are really doing some excellent work by allowing me to work with them to find those complaints and cases where we know that disparities are happening. So we're looking at what's happening in hospitals around Black maternal health. What happens when Black women and Hispanic women and Native women go into the hospital and they're being screened for drugs, or, you know, doctors are not listening to, I have pain. During COVID, you know, the thing that was most interesting, and it was almost unbelievable, is that as testing centers were being set up around the country, they were being set up in communities where Black people didn't have access. Like Red Hook, Brooklyn, where a lot of people don't have cars, had drive-through testing centers. But you couldn't walk up and utilize it. You know, that really tells you how people are not always thinking in a more inclusive way. We received lots of complaints and just letters from individuals during COVID that were talking about what was happening in certain parts of the country. I won't name the parts of the country, but you know, folks were going in, they understood that their older family member who was of color had COVID. And instead of the hospital being treating them, they were being sent home to hospice, and these people died. And these are things that, and these are stories that are not coming to us in the forms of complaints. These are coming straight out of the news. You know, so we're like drilling down in the news and finding out. And one of the things that we realized is that maybe as an agency, HHS hasn't done that great of a job in talking to Brown communities. Because we know that when we pay a lot of attention to an issue, particularly disability, you know, I don't know if you guys have ever noticed, but if you ever look or just look for a sit-in in disability, HHS regularly has members of the disability community, and they'll converge on all of the federal centers around the country and demand that HHS do something about whatever the particular issue is. And unfortunately, that's not something that happens across the country. You know, I'm an African-American woman. I'm also a person with a disability. So I'm, you know, we tend to look at issues that are Brown only, but I'm Brown. You know, I'm a woman. I'm a person with a disability. I just got my AARP card a couple years ago, so I'm in the age category. And so sometimes when we've looked at complaints, we may look at the issue that kind of jumps out first, person has a disability. But in that, being a person of color with a disability, that is a double whammy, because sometimes people cannot articulate what it is about being Brown has caused someone else to treat them unfairly. And so as we're doing our work with our staff, we're really making sure that we're not just looking at the single issue that tends to be a little bit easier to prove because there's a lot of case law about disability. We want to look at what's happening around ageism. We want to look at what's happening with race. We want to draw that connection between when does implicit bias raise to the level of race discrimination. And if you, in your free time as students and as faculty, if you try to look for some case law, there's like zero case law on what does a Title VI violation look like in healthcare. And that's because doctors have a lot of discretion. And that, as you know, as Kim mentioned, folks are not owning what's really, really happening. So what we've just, so what we've decided to do is that we open, so we can get complaints, but we also have a process of, it's called a compliance review, where we on our own can initiate investigations. And so now we're initiating investigations around the country to look at a variety of issues, issues related to Black maternal health, issues related to racial disproportionality of children in foster care. That's my particular area of specialty when we look at the number of children who are in foster care and what happens to them. But it's not just that they're in foster care, they're in residential treatment facility centers. And so these are healthcare entities that are subject to Title VI of the Civil Rights Act and Section 1557, which covers a variety of activities, but targets health activities and programs that are funded by HHS. So I want to give you a couple of examples of things that we saw during COVID that really caused us to, because we weren't receiving complaints, we felt there was an opportunity for us to put some guidance out to remind healthcare providers and those that support healthcare providers of what their obligations are in a public health emergency. And so what we were finding out is that racial and ethnic minorities were experiencing excessive wait times when they were calling to find out where there was testing. And a lot of that was because there was not language assistance available for people who didn't speak English. African Americans, Indigenous people, and Hispanics had limited access to vaccine centers because of locations. I mentioned the drive-through in Red Hook. Vaccine center operation hours were, 9 to 5, but we know that a lot of brown people work in the service industry, and so that's not available to them because they'd have to take off from work. And then there was general misinformation about vaccine availability, and that states in their effort to respond to this emergency were using digital ads. Well, if you're in Lowndes County, Alabama, there is no Wi-Fi. My family's from King William County. I swear to God, like 5 years ago, they laid down some wires for Wi-Fi, and I was like, "Are you serious?" But this is America, right? If we take the approach that we're only looking at urban centers where there's a lot of infrastructure, it's great. But when you're talking about outside of urban areas, it's just not happening. And so people who needed good information about vaccines and testing centers weren't even getting access because the folks who were planning weren't even thinking about those as individuals. And that was an oversight, right? And that's also a sign of bias, right? Everyone is like me. So therefore, what I'm going to put out is perfect. Well, it's not, right? It's a bias.
Yeah, I can talk about the case, but I think we were also, obviously all of us were seeing, when the vaccine first came out, it was largely based on online signups and enrollments for those processes. And obviously we were missing whole chunks of the community who were at greater risk because they were in the essential worker positions. And perhaps, one, they couldn't make the vaccine appointment times that were available. And two, perhaps they weren't able to sit there on their phone all day while they teleworked and try to sign up for their vaccine appointments. So we were trying to address those issues as well during the COVID pandemic and with their guidance, just to remind providers that their civil rights obligations don't stop just because we're in a public health emergency. We also had a case here in the region, and just to be clear, our region covers Pennsylvania, Maryland, Washington, DC, Virginia, West Virginia, and Delaware. And so we had a case that we expedited the resolution to through our expedited case processing process. And there was a large health system in the region where, there was a gentleman who was critically ill. His primary language was Spanish. The language of his wife was Spanish, and the hospital wasn't providing her with language assistance in order to keep her apprised of his condition, or, when his health was deteriorating and she was in great distress, she didn't have any way to communicate with them at the time, there was a limit of, on-site interpreters available due to the pandemic, and the hospital just didn't have it together with connecting her with remote services to communicate with her either. And so we actually got this complaint from somebody who was working with her child in her public school system, who advocated for her. And we were able to intervene, and within 24 hours, we were able to get the hospital to contact her with the appropriate language services so that they could speak to her about her husband's condition and keep her informed, and so that she could have that ability, as Kim was talking about, to make informed decisions about the plan for his care. And so that's just one of the very real examples that we were dealing with here in the region.
So I just want to go back a bit to Kim's presentation, and particularly focusing on what happens to Black women. And as she mentioned, Black women are 4 to 5 times more likely to die during childbirth. And those numbers tick up even further when you're a Black woman over 30, and you're a Black woman with a college education or an advanced degree. You are 5 to 6 times more likely to die during from a pregnancy-related complication than white women who are similarly situated. And Black women with a college education are 1 to 2 times more likely to die than white women without a high school education. So those are really jarring numbers. Something is happening. And so it's not enough for us to just, say, oh, these things are happening. What else can OCR do? So OCR has a medical school curriculum, and every summer we train with students at 20 schools.
I think it's 20 schools. The schools receive specific, they're specifically selected through some sort of grant process. But we're not limited in just providing this presentation to those schools. We can go out, we've done this for nursing schools in the region. We've also done it for dental programs. And so I think it's a really important tool to have in our toolbox to train new medical students, dental students, nursing students on these issues of cultural competency and, just being aware of their implicit biases and in their day-to-day interactions with their patients. And so that's something that's also available, and the regional team is always happy to get out there and do that presentation as well. And it's focused on issues also of effective communication. So for folks who, are deaf or blind, we talk about auxiliary aids and services that staff should be using with people with disabilities in order to give them equal access and understanding of their care. We also talk about language access in that presentation as well, and the importance of everybody being able to participate fully in their care.
And I think it's particularly important when we're talking to folks like you who are in school, because I remember when I was in law school and I went to #1 public interest law school in the country, CUNY School of Law. CUNY's foundation is built on, social justice and equity. And at no time did anyone ever say to me, we did the con law classes, but we did not focus on the various federal civil rights laws and how we could use those as tools to advocate on behalf of our clients. So we've been talking about, and, I'm glad that, we've had this opportunity to talk with you about partnering with law schools to provide this information in real time. As you're thinking about clinics and seminars and, new initiatives, think about how this next generation can really change how life happens in a variety of fields by focusing on how to develop new case law. I worked in, my clinic was in domestic violence. And so, we were, using our tools in New York to figure out how we could help people. And some of us had some special experiences. I worked in child welfare before then. So, I was trying to do the intersection between, domestic violence and child welfare. You guys may be doing something very, very interesting here. And I would challenge you to look at implicit bias. There is zero case law on this. And this is an area that needs to be developed. The federal civil rights laws, Title VI in particular, has lost much of its teeth because of a variety of court opinions over the last couple of years. And federal agencies that have responsibility to investigate cases using a disparate impact theory. It's challenging. It's challenging, particularly in the area of health.
And we're the only game in town for that
We're the only
after
game in-
Alexander versus Sandoval.
Right.
So, I
Right.
mean,
So if we can't do it, right,
right.
nobody can do it, right? Because individuals can't bring a disparate impact claim under Title VI. But I just would really encourage all of the professors and all of the great minds and young folks that are here to really think about them. Because if we can turn the corner on health, everything else falls into place. I cannot work if I do not feel well. I cannot maintain my apartment. I cannot do anything if I don't feel well.
Cannot care for my children
I cannot
appropriately.
care for my children. So I think it's really a great opportunity for this school and other schools to think about, how you can join this fight, because we only have, certain periods of time in America where we're looking at these kind of issues. This is our time. The White House has a blueprint on Black maternal health. Each department within HHS is required to do something around Black maternal health. We're doing investigations, we're doing outreach. We have all of our scientist colleagues and social scientist colleagues who are writing about what is happening with Black women and Native women in particular. So, we're trying to, take all of that data and advance the ball. And we hope that, one of these investigations will lead to some sort of resolution where a lot of other hospitals will say, aha, because that's how hospitals were desegregated, right? HHS or HEW back then was doing a lot of investigations and everything was falling flat. Then they found 2 hospitals and they were able to issue a violation. And guess what? Hospitals started desegregating. They started taking things seriously. And I think we can turn the corner in health by all of us partnering together. We're the law enforcement arm. We'll do what we can do on our end, but it would be helpful as you're thinking about things, as you're developing facts, as you do law school think tanks. I used to hang out with my friends, smoke cigarettes and talk about, how we could change the world, right? And, literally I'm in a position and Jamie's in a position and you're in a position today where we can really change the world. So I just would really encourage that. And if you would reach out to Jamie, if you'd like to talk with her, if you'd like, we do internships. We don't pay. I'm sorry. I'm just saying we don't pay. Okay. So that's how it is sometimes. But, if you would be interested in spending a summer with us to help us do some of the work, we really would encourage you to think about how you can lend your voice to what is really an exciting time today.
Does Drexel still have the medical legal partnerships in the communities? Is that something that's still happening? No? Okay.
Maybe.
Okay. Well, I was gonna say you could leverage that, but yeah.
Thank you. Thank you both so much. So,
Back to me on the mic. I know we're over for time, but I just wanted to see if there are any burning questions in the audience for any of our speakers while we have them here. I'm going to take moderator's privilege and ask one question and then we'll wrap. Vanessa, for you, I was wondering if you could just give us a little insight as to whether and where healthcare providers are talking about these issues, whether it's about racial bias and discrimination, about racial health disparities, about abolition that you talked about, where you're seeing that. And then for Jamie and Carla, kind of if you could speak just briefly to where we most need resources. And you talked a lot about the sort of gaps in education and just basic rights awareness. Is that a place where you would like to see more investment? Or are there other areas where, if we had the time and the money and all of the resources that we should be focusing?
Thanks for the question. I guess are these conversations happening? And if so, where? I think the answer to that is yes. Could we be having more conversations in larger groups more frequently? Absolutely. Not talking about it enough. But I think there's definitely a small but mighty and growing body of like healthcare workers that are engaging in these really critical discussions. I think like, first of all, like White Coats for Black Lives, the National White Coats for Black Lives movement, which kind of started in 2014 as this like Black student-led, Black medical student-led collective that was, you know, at the time of the Black Lives Matter movement, as that was kind of like starting to burn up in 2014, kind of collectively getting together, understanding this like isolation that we were feeling as like Black medical students, where the world was crashing down around us. But like the lecture halls, like it was never being acknowledged, being able to kind of be in coalition with that, and also being able to simultaneously agitate within our classrooms, and decry anti-Blackness and decry police brutality has now really like blossomed into this like really beautiful national organization that continues to be student and trainee directed, is very like much founded in like Black radical tradition and Black liberation. They like kind of host a lot of really important conversations. I think the Cops Out of Care movement is like a national collective that's specifically dedicated to addressing the presence of security officers and like armed officers and unarmed like police within our hospitals, and how do we get them out of there. And then there is also Interrupting Criminalization has a Beyond Do No Harm network, which like 2020, like in the last couple of years, published the set of 13 principles. This is basically just like, hold on, I have the mission statement. Discussing principles and strategies toward a better world through a like vision of healthcare workers, organizers, abolitionists, justice organizations, and impacted people. And basically like looking at how do we recommit to caring by refusing to like engage in these systems of harm. And I'm just going to read their 13 principles because I think they're really succinct summary of like the different ways that we criminalize people within health. So the first principle is to end police and ICE presence in hospitals and in or near healthcare facilities. The second, to end information gathering and documentation that is not directly relevant or related to the person's course of care. The third, end screening and testing without explicit and informed consent. Number four, end the practice of calling police on suspicion of fraudulent identification documents. Number five, stop calling police on people with unmet mental health or medical needs. The sixth, stop calling police on people in possession of, distributing, or using drugs. Number seven, end mandated reporting. Number eight, stop supporting prosecution in cases against people who manage their own care or offer community-based care. Number nine, stop participating in or supporting prosecution in cases of transmission of infectious diseases, including HIV. The 10th, stop participating in or supporting prosecution in cases related to drug use or overdose. Number 11, stop providing and or sanctioning substandard or violative care for people who are in custody or incarcerated. 12, stop collaborating with the criminal punishment system to violate people in custody. And the 13th principle is stop punishing other healthcare providers, public health workers, and researchers. So their entire like manual of principles is like available to like read and digest online. And I think that, you know, those kind of three groups of folks, there is definitely a lot of overlap in terms of who is participating in all of these things. But I think that those are really where a lot of the groundwork has been made.
So again, I think ensuring that, you know, folks who are doing the work have the education and the tools that they need to understand what the laws are and how they can be used as real tools to turn the tide on some of the disparities that we're seeing. I think it's a real important space to develop some advocacies for underserved communities. There tends to be some thought, and we've challenged some of our colleagues about it, that the NAACP speaks for the entire African-American community. And actually, the NAACP is very active in the South and not so much in the Northeast. And so there are many other groups that folks could be partnering with. I will be looking at the National White Folks because I was not aware of that, to bring, one, to bring education to communities, two, to really serve as advocates. I think it was last summer, there was a coalition of Black parents and their attorneys who went to Geneva for the conference on eliminating racial discrimination. And they raised up to this, impressive body what is happening to children in foster care and Black families. And as a result of which, there are some initiatives that are happening around the country that would have never happened had there not been folks who were talking to the parents and the children to share information. I think the other thing is, if in the various clinics, and I'm not sure the clinics that are here, but think about class actions that could be brought. You can file a class action with OCR, you file one with the Department of Justice. There's a class complaint, and we can take it from there. Sometimes there's not a individual who wants to come forward, but there may be an entire community. We know that there are things that are happening in North Philadelphia that don't happen in other parts of the city. We talked to some advocates about it, and we've encouraged them, especially around drug testing of Black women and Hispanic women who go in to have their children, labor and delivery patients. They're getting tested, and in other communities, they're not being tested. And so we think that there's some opportunities there to address some disparities, but it is going to take some leaders because folks don't always know where to go.
I think I would just mention another area that we're kind of delving into now under this administration is the area of environmental justice, and how, we can get into that space with how we fund public health entities and state and local departments of health, because your environment is really a big social determinant of how your health outcomes are going to end up. So if you want to talk a little bit about Lowndes County and our joint investigation with DOJ, I think that would be helpful for people to know, just so they can see the work in our space.
Yeah, so, speaking of environmental justice, Lowndes County is in Alabama. This is a community where folks, these are the descendants of enslaved people who live on land that was formerly good for cotton, terrible for waste disposal. And there had been a number of studies to show that the people in the community had hookworm, which is something that, in the United States was eradicated like in the 1920s. And so that there would be a community where it's alleged that there was hookworm was really quite disturbing. We know that the UN had been down there twice to look. We know Jane Fonda, Bernie Sanders, all kinds of folks. Well, there was one particular advocate, Catherine Flowers, and she sits on the White House Council for Environmental Justice. She's from Lowndes County. And so she filed a complaint with an advocacy group and really demanded that HHS and Department of Justice go down and do an on-site investigation. And we did. And we were able to, and so, we're not the EPA, so we don't have jurisdiction over environmental issues generally, but where there is a health impact, and that was our hook. And what was happening? Well, we know that when children are exposed to hookworm or other bacterial diseases, all kinds of things happen with their development. Same thing with older people, same thing with children. And so we partnered within HHS and the Department of Justice to have our colleagues at the Centers for Disease Control to work with the state of Alabama to actually investigate what is the impact on someone's health if they're exposed on a regular and daily basis to unprocessed sewage. And so that's happening. We also have worked with the state to identify grants that HHS provides to help them develop an infrastructure so that these communities that really have no access will now have at least access to healthcare. And then we work with our partners at the EPA to find out some additional monies that were there. So it's like a whole system of government approach to something that shouldn't be happening. But guess what? That's not the only place. Like we know in Mississippi, when the rivers overflow, there's all kinds of bacteria that get into people's water supply. We know that there's a corridor from Louisiana to Mississippi where there are nothing but plastic companies, and there's a higher population, higher incidence of children having severe asthma and cancer. And so while we can't regulate those entities, we can regulate the health departments who have, as part of their fundamental mission, to protect the health of the communities. And it's very critical to protect the health of brown communities, because these are where there are less resources for healthcare. And so we've been, we did our violate. Well, we didn't do a violation. We entered into an
It's more or
interim
less a-
settlement agreement.
Yes, it's more or less a resolution agreement.
But the hook for us is that we give billions of dollars to the Alabama Department of Public Health, because they accept Medicaid and all kinds of other funding, and they get research monies from the NIH. And if you don't comply with the various civil rights laws, we have the authority, if we find a violation, to suspend those funds. And so there's a lot of incentive for states to come on board, as Alabama did. And, and I think what also helped is that everyone was going down to Alabama. It was always on CNN and MSNBC and Fox News. And so the eyes of the world were on them. But there's so many other communities where folks are just looking for someone to turn the spotlight on them. And that is really an excellent opportunity, because literally every public health department in the country has an obligation to protect health and to take active steps. And so that's another area that I would encourage folks to think about as well.
Well, this has been a really rich conversation today, and I know that it will be part of an ongoing conversation here and elsewhere. And to that end, if you're not getting emails from the Drexel Health Law Program, I invite you to sign up for our Vital Signs newsletter so you can learn about upcoming programming. And on behalf of the Health Law Program here, just our heartfelt thank you and appreciation to Kim, to Vanessa, to Jamie, and to Carla for sharing your so much information, so much expertise, and also some inspiration. Thank you for the work ahead. So appreciate you all being here. Take care.
I'm